know it is which cranial nerve? It is 12th cranial nerve. Okay. So it's, 11th cranial nerve. It's purely motor. It consists of two roots. One is cranial root and the other is spinal root. So you can see here, this is brain stem where we have midbrain, pons and medulla oblongata. So from here, if you observe, so the part of this accessory nerve is coming from the medulla oblongata, which is called as cranial root, and the part of it is also coming from the spinal cord, which you call as spinal root. So both spinal root and cranial root will join and they will come out through jugular foramen, which is the foramen which we see in the skull bone. Through jugular foramen, this accessory nerve comes out. Once it comes out, you can see it is entering in the posterior triangle and then it is supplying two muscles. One is sternocleidomastoid and the other is trapezius. Okay. So accessory nerve is 11th cranial nerve. It's purely motor. What is the meaning of motor? Motor in the sense it is supplying the muscles. Okay. Then, so it consists of cranial and spinal root. Cranial root is accessory to the vagus. That means what? Vagus is 10th cranial nerve, accessory is 11th cranial nerve. Both will work together and they give supply to the muscles of the pharynx and all. Okay. The spinal root has an independent force. It is entering into the neck and it is supplying the sternocleidomastoid and trapezius. Okay. Then. Now this picture also helps us to understand the same thing. See, this is our 11th cranial nerve. Okay, we have cranial root and then this is spinal root coming out through jugular foramen. Okay, cranial root will join the vagus, spinal root will supply sternocleidomastoid and trapezius. Okay, this is like whole section like you are finding. This is pons, this is medulla oblongata, this is spinal cord. From the medulla oblongata, we have this root, red in color, that is cranial root. And this whole thing you are finding is the spinal root of the accessory nerve. So cranial root and the spinal root both are joining. The cranial root, it's very clearly shown, excuse me, it is distributed through vagus nerve. And spinal root, it is coming down and it is supplying the trapezius and sternocleidomastoid. Okay. So suppose if it comes as an essay, torticollis will be the designed question. The question will be designed. The person has come with wry neck and torticollis. The neck is turned to one side. What may be the nerve which is involved? Write the details like course of the nerve, nerve supply, everything will be asked. Parts of the nerve and everything. So like that it will be framed. So consists like this accessory nerve. It has cranial part and spinal part. Okay. So now components are, so many components are given. So what you do is, see from this picture, you have like special visceral efferent fibers. Okay. Efferent means they will go to the certain muscles, motor in function. Efferent and motor is the same thing. Visceral means going to visceral organs and they are special fibers. So functional components, what you will write is, because if it comes as an essay, you have to write. I cannot simplify this. So we have components like special visceral efferent fibers, okay, which are actually coming from here, nucleus ambiguous, okay, and from the cranial root, okay. The other like functional components, we have somatic efferent. Somatic means they are going towards the surface of the body and they are also motor in function. That means they are going to sternocleidomastoid and trapezius. Okay, so cranial part. So cranial part is arising from the nucleus ambiguous and also dorsal nucleus of vagus. Okay, so superficial origin, the posterolateral sulcus of the medulla oblongata. This whole thing is medulla oblongata only, and it is coming from the posterolateral sulcus of the medulla below vagus. Okay. So again, cranial and spinal parts are given two different colors. So you can see this is medulla oblongata and this is spinal cord. In the medulla oblongata, the nucleus from where it comes is nucleus ambiguous. Above this, we will see vagus nerve, and below this, we are finding the accessory. So the accessory's cranial part is distributed through vagus, and this is the spinal part, which is coming from long, lengthy, like root of origin it has. Okay. So the fibers are general, somatic, efferent, supplying sternocleidomastoid and trapezius. You can draw whichever diagram is simple and easy for you. This is actually the floor of fourth ventricle where all nuclei are shown. So whenever we do the cranial nerves, so this picture always comes to just let us know like where exactly this nucleus is situated. So like we have seen here, this violet in color, whatever nucleus we have is the nucleus ambiguous. So this nucleus ambiguous is an area from where you are finding the origin of the accessory. Different pictures are shown, but all pictures are emphasizing the same fact that it has cranial root and spinal root. Okay. Now, see, this is our medulla pons, medulla oblongata, and spinal cord. This is pons, this is medulla. Now, the accessory nerves is this. Okay, so this is the cranial part, and then just below this, you have the spinal part. Okay, then accessory nerve is this. So at the superficial origin, like when it is starting from the medulla oblongata, it has 3 to 4 rootlets which join and pass up to the jugular foramen. There it joins the spinal root to form the trunk of accessory nerve. It emerges out through middle compartment of jugular foramen. So if you have some memory from what you have studied previously from jugular foramen, we have other cranial nerves also are coming out. 9th, 10th, 11th cranial nerves and internal jugular vein comes out through jugular foramen. 9th is glossopharyngeal. Sometimes what are the structures passing through jugular foramen? There may be a question. So structures passing are glossopharyngeal, vagus, spinal accessory, internal jugular vein. Okay, 9th, 10th, 11th cranial nerves and internal jugular vein. So after coming out of this jugular foramen, the two roots, that means cranial and spinal root, separate. We know cranial root goes and joins the vagus nerve and it gets distributed. You can see this is our jugular foramen. I said, what are the cranial nerves entering into the jugular foramen? 9th, 10th, and 11th. Okay, 9th, 10th, and 11th cranial nerves will enter. 12th has a separate passage, hypoglossal canal for hypoglossal nerve. Okay, so this is our distribution. Now you see here. So jugular, see this is vagus nerve and this is our accessory. So the cranial part is joining the vagus and it is supplying, is dividing into pharyngeal branch, laryngeal branch and cardiac branch. That means it goes and supplies pharyngeal muscles, laryngeal muscles, and it forms the cardiac plexuses, what we have studied when we were doing nerve supply of this heart. Okay, so this is all like all pharyngeal muscles, like pharyngeal branches of vagus supply all muscles of soft palate, all muscles of pharynx. Exceptions if you will skip also no problem. Pharyngeal muscles, muscles of pharynx and muscles of soft palate. To be more specific, except tensor veli palatini and stylopharyngeus. If you can remember. If you don't remember also, these 2 points are enough. So along recurrent laryngeal nerve, that is one of the branch of vagus. So this cranial part of accessory is supplying muscles of larynx. So all muscles of larynx, all muscles of pharynx, all muscles of soft palate, okay, cardiac branches, okay, these are all coming from the cranial part of the accessory which are distributed via vagus. Both are working together to supply these structures. So that's how we are done with cranial part. Once we are done with cranial part, we are doing spinal part. So spinal part of the accessory nerve, deep origin, from where does it come? So like if you remember this picture, so long lengthy, like this whole thing, C1, C2, C3, C4, C5. Up to C5 segment, you have the origin of the spinal part of the accessory nerve. It is entering into the foramen magnum. It is joining the cranial root. Then it is coming finally out, coming through the jugular foramen. Then it is entering into posterior triangle. Very simple. Supplying those two muscles. Very, very simple. So deep origin, so it is coming from the ventral gray matter of upper 5 cervical segments. Superficial origin, these arise from the spinal cord from upper 5 cervical segments again, in between dorsal and ventral parts of the spinal cord. Okay. Then, so once it comes out, we know pretty well, it is coming out through the jugular foramen. Once it comes out through the jugular foramen, it is entering into the posterior triangle. It supplies the sternocleidomastoid and trapezius. It is proprioceptive to these muscles. Okay, fibers arising from the spinal cord ascend and along with fibers of next segment become a single trunk. They run behind ligamentum denticulatum. Ligamentum denticulatum is nothing but the extension of pia mater. This trunk enters the cranial cavity passing through foramen magnum. Just now I have shown. Then in the cranium, it joins the cranial accessory, comes out through middle compartment of jugular foramen. Okay, so it comes out through jugular foramen and it gets separated from cranial part. Then it crosses the tip of the transverse process of atlas. Atlas is for cervical vertebra. Crosses that and enters into the posterior triangle. So course in detail, it runs medial to styloid process, stylohyoid. Actually, everything is shown here. This is styloid process, stylohyoid, posterior belly of digastric. It crosses all these, the spinal part. Then it runs over the sternocleidomastoid. It runs over the levator scapulae, which is one of the floor muscles of the posterior triangle, to enter into trapezius. Okay. So that is, it passes, the same thing is given here. It passes deep to sternocleidomastoid, appears in posterior triangle, terminates in trapezius. Okay. So communicating branches, that means it has also communications with cervical nerves like C2, C3, C4. Okay. So distributing branches, two muscles, sternocleidomastoid and trapezius. So I told you question will be framed like torticollis. So if this nerve is irritated due to cold conditions, cold weather, or if you are sleeping an improper pillow or muscle catch is there, so that is spasmodic torticollis. It is clonic spasmodic contraction of sternocleidomastoid due to irritation of spinal accessory nerve. Okay, beta? So that finishes two essays, in fact, we have done, isn't it? So what are those? Punching movements means you have to remember punching muscle is serratus anterior. An examination like on the medial of right scapula was very prominent. That means winging of scapula. Medial border of scapula is prominent means long thoracic nerve is paralyzed. Okay, what is your probable diagnosis? The probable diagnosis is like paralysis of serratus anterior. Condition is called winging of scapula. Name and describe the muscle involved in this condition. Obviously, it is serratus anterior. Which nerve was involved? So that is long thoracic nerve. Okay. Then, so we will see the root value and name the other pectoral muscles. What are the pectoral muscles we have, beta? He is asking us to just names only. Can you name the pectoral muscles? Pectoralis major.
Pectoralis major, minor.
Subclavius.
Pectoralis major, minor. Subclavius.
Okay. So let me open the PowerPoint. Now see here. So let me discuss in detail only. I'll show you the muscles and discuss. See, in the pectoral region, we have already studied mammary gland in detail. If you remove mammary gland, under this we will see pectoralis major muscle. Once you remove pectoralis major, you will see this is pectoralis major. Below this, you will see pectoralis minor, and then we will see subclavius. Okay. So these are the muscles we see here in the pectoral region. So pectoralis major, pectoralis minor, subclavius, and serratus anterior. These are the structures what we should know in pectoral region. So this thing he has framed as essay. Okay. So the cutaneous nerves you need not know. I don't want to trouble you with unnecessary facts for now. Okay. So muscles we should know origin, insertion, nerve supply, action. Beta, we'll do it. So pectoralis major is a thick triangular muscle, broad at its origin, narrow at its insertion. It forms anterior wall of axilla. So upper border is separated from the anterior border of the deltoid by deltopectoral groove. I'll show you this. Okay, this is like twisted. You can see the upper fibers are coming down, lower fibers are going up. Hence, it is rounded and twisted, and it forms the anterior fold of axilla. Okay, so this is deltopectoral groove, pectoralis major and deltoid. In between, you have a groove where we have cephalic vein. So the origin, it has fibers coming from clavicle, it has fibers coming from sternocostal head. So clavicular head is coming from medial half of the anterior surface of the clavicle, sternocostal head, sternum and costal cartilages. So lateral part of the anterior surface of the sternum up to 6th costal cartilage, then 2nd to 6th costal cartilage, and aponeurosis of external oblique of abdominis. We have studied this muscle when we were doing rectus sheath, isn't it? Then I told you there is a vein in the deltopectoral groove. What is the name of this vein? Cephalic vein. This is pectoralis major. This is deltoid. This is serratus anterior. Okay. So you can see clavicular head coming from the manubrium and the body of the sternum, and also from the costal cartilages. Okay. Then insertion. See, these fibers are converging and they are forming bilaminar tendon. Two laminae. It has anterior lamina and posterior lamina. Okay, which is around, like if you just check, around 5 centimeters broad, inserted into the lateral lip of the bicipital groove or intertubercular sulcus. Okay, in U-shaped manner. So at the lower border, you will see both laminae. That means this is the lower border. Anterior lamina and posterior lamina are continuous. The lower border. Okay. So all these details not required. Nerve supply. Medial and lateral pectoral nerves. These are the nerves which we study when we do the brachial plexus. From the lateral cord, we have lateral pectoral nerve. From the medial cord, we have medial pectoral nerve. Isn't it? So these two nerves are supplying the pectoralis major. Okay. So what does this do? Say, acting as a whole, the medial rotation and adduction of shoulder joint, which you can see here. Clavicular head, flexion of shoulder joint. Sternocostal head helps in extension to bring flexed humerus to the side. 1 or 2 movements are enough better. Okay. Then this is exception muscle, you need not know. Next, we have pectoralis minor. So pectoralis minor lies beneath the pectoralis major. Okay. So from where does it come? See here. See, 3rd, 4th, and 5th ribs. This is 1st, 2nd ribs gone. So costochondral junctions. This is cartilage and this is bone. The junction point you call as costochondral junction. So it is arising from 3rd to 5th rib from costochondral junctions, and in between you will have intercostal muscles also. The fascia covering external intercostal is also giving origin to pectoralis minor. Where is it getting inserted? At least one word you can remember, that is coracoid process of the scapula bone. Okay, you need not write much in detail. At least if coracoid process is coming, then also we will give you marks. Insertion of pectoralis minor. The nerve supply, we have medial and lateral pectoral nerves. Action, so along with serratus anterior, pectoralis minor helps in like protraction. Okay, protraction is this, retraction is this. Protraction, when you bring forwards. Okay, so it depresses the shoulder along with levator scapulae and rhomboids. Okay. So then next, 3rd muscle, very small muscle we have, that is subclavius. Okay. So this subclavius, what does it mean? Below clavicle, you have this muscle. That is the meaning of subclavius. So origin at the junction of 1st rib and its costal cartilage. That means costochondral junction of 1st rib. Insertion is subclavian groove, what we find in the inferior aspect of the middle 1/3 of the clavicle. Nerve supply, nerve to subclavius, very simple, nerve to subclavius. Action, it steadies the clavicle during the movement of shoulder joint. Okay. This again is a separate 5 marks or 3 marks question better, clavipectoral fascia. Okay, because now you will understand well if you are reading with this topic. I am teaching you this also. See here. In the neck region, I said we have investing layer of deep cervical fascia. The same fascia, when it enters into the thorax, it has been named as clavipectoral fascia. Clavi means clavicle and pectoral means pectoral region. So this fascia is found below pectoralis major muscle, because now you see pectoralis major is cut. Below pectoralis major, we have pectoralis minor, isn't it? So covering this pectoralis minor and subclavius muscle, we have a fascia. The name of this fascia is clavipectoral fascia. There are certain structures piercing clavipectoral fascia. That is 3 marks question. What are the structures piercing clavipectoral fascia? You are finding one artery. Thoracoacromial artery is a branch of dash. Second part of axillary artery. We discussed
Axillary artery.
axillary artery. Yeah, very good.
Yes, ma'am.
Very good. Then we have cephalic vein. Okay. And then we have also lateral pectoral nerve. Okay. Lateral pectoral nerve. Just a minute. Beta. These three structures piercing the clavipectoral fascia, lateral pectoral nerve, cephalic vein, thoracoacromial artery. Now, about clavipectoral fascia, it is a strong sheet of fascia stretching from pectoralis minor and clavicle. Okay. Then medially, it fuses with the anterior intercostal membrane. This white membrane, whatever you are finding, is the anterior intercostal membrane, especially from of upper two spaces. Then laterally, you can see here, it is attached to coracoid process and blends with coracoacromial ligament. That means this point better. If you cut deltoid, you will be able to see it more clearly. Coracoclavicular ligament blends with. Then above, you are finding clavipectoral fascia is splitting to enclose. I already told you two muscles. One is subclavius and it is also splitting to enclose pectoralis minor. Okay. Then so posterior layer of this clavipectoral fascia, it blends with the axillary sheath. Okay, axillary sheath we will find surrounding the axillary vessels. Then, so lower down this clavipectoral fascia is splitting to enclose pectoralis minor. Then it reunites at the lower border of the muscle and extends downwards. Can you see it is extending into axilla like this? So that extension downwards into the axilla is actually called as suspensory ligament of axilla. Suspensory ligament of axilla. Okay. Structures piercing the clavipectoral fascia. Write the names: cephalic vein, lateral pectoral nerve, thoracoacromial artery, and everywhere we have lymphatics. Okay. Thoracoacromial artery, we know 4 branches. I gave you the code A, P, C, D. Acromial, pectoral, deltoid, and clavicular. Okay. Now coming to the muscle which has worried you so much on the day of exam, isn't it? That is serratus anterior. So serratus anterior is the muscle which is actually coming from the lateral aspect of the upper 8 ribs, and its insertion goes to the scapula bone. The scapula bone has like dorsal aspect and then it has costal aspect. Okay, costal aspect, medial border, it gets inserted. So it's a broad sheet of muscle which forms the medial wall of the axilla. Origin is, if you just count, it has 8 fleshy digitations from outer surface and the upper borders of the upper 8 ribs, fascia covering like intervening intercostal muscles. Insertion, all digitations, I said it is going deep to the scapula bone. You just remember medial border of the scapula. Only this word, costal surface along the medial border of the scapula. Remaining digitations even, actually you can remember very easy only. See here, this is the medial border of scapula. In this way you can remember easily in fact. So this is costal surface of the scapula and all along the medial border we are finding serratus anterior. So we have first, second to third and remaining 4 to 5. See, first digitation is coming from the superior angle from here till here. Okay. Then from here till the spine we have one digitation, and from here till the lower border we have second digitation, and the last digitation we will find in inferior angle. Because it has come as an essay, you are supposed to write 1, 2 and 3. Let us see in detail. First digitation is at the superior angle to the root of the spine of the scapula. Second and third digitations along the medial border. Last 5 digitations along the inferior angle. Along the inferior angle. That much you write, it is enough. Okay, this is first digitation. Okay, so from the superior angle to the spine. Along the medial border, you have second digitation, and along the inferior angle, you have third digitations. Overall, 8, no? 5 here, 2 here, 1 here. 5 plus 2 plus 1 is 3. That is the easy way to remember. Okay. Now coming to the nerve supply of this muscle, the long thoracic nerve, it's also called as nerve of Bell. So we are also asked what is the root value. C5, C6 and C7 is the root value. The nerve is entering into the axilla through the apex of, so which is this nerve? See here, this one, where arrow has been shown. See, this is long thoracic nerve which is running over serratus anterior. Okay. So nerve enters through the apex of axilla and passes downwards along the medial wall of axilla behind mid-axillary line. So C5 root supplies upper two. You need not give so many details, but this is enough. C5, C6, C7. You will get confused and you can't remember also. So when the entire muscle is contracting, what does it do? Along with pectoralis minor, it protracts. I said this is protraction, this is retraction. And then protraction is also accompanied something like pushing and punching movements. Okay, that is something like this, put like this movements. Okay, then the actions of serratus anterior is antagonized by contractions of, that means stopped by other muscles like rhomboids and middle fibers of deltoid. You need not remember all these things also. See, suppose if there is paralysis of this long thoracic nerve, you will see medial border of scapula becomes very prominent, which is called as winging of scapula, winged scapula. Okay, so that is. So I hope you understood better. So this was your second essay question. Okay. So we'll move to the next questions. Are you finding connective tissue on the screen? Yes.
Yes, ma'am.
So connective tissue. Now, what is the question he is asking us? Yesterday, when some biomolecules, what you find in extracellular tissue, I told you, whatever extracellular area what we have is actually connective tissue. So he's asking us different types of connective tissues. So basically, connective tissue is nothing but the tissue which gives structural and metabolic support to all other tissues and organs throughout the body. Okay. So that means it gives support, it is a medium for exchange, it gives like protection because it has lymphocytes, it is also storehouse of fat. Telling you quickly what do we find in connective tissue. We have different types of cells like fibroblasts, fibrocyte, plasma cells, eosinophils. If a question comes, what are the cells of connective tissue also, you should be able to write so that I'm telling you everything. Okay, neutrophils, eosinophils, basophils, small lymphocytes, large lymphocytes, macrophages, mast cells, everything. So now cells like mesenchymal cells are actually called as totipotent cells, which are actually capable of differentiating into any type of cells. Okay, so these are also one type of cells in connective tissue. So fibroblasts are the cells which are actually forming, suppose if they are found in cartilage, they are responsible for the formation of collagen fibers, whether it is in bone or cartilage or basement membrane or in blood, anywhere, wherever we have the formation of collagen fibers, that is actually coming from fibroblasts. Actively working fibroblasts are there. Once they do the function of producing collagen fibers, they get transformed into fibrocyte. Okay, they get trapped. Okay, basically the function of fibroblasts is they synthesize collagen fibers. So adipocytes are nothing but fat cells. These are also one of the cells in connective tissue. So adipocytes store fat, and the once fat is stored, the nucleus is pushed to one corner, and this appearance is called signet ring appearance. Okay. So we have pigment cells as we find in our skin, which are responsible for different colors. Isn't it? We find in the iris also. Macrophages for the purpose of phagocytosis. Plasma cells, they are actually derived from B lymphocytes and they produce antibodies and kill the microorganisms. Mast cells also, they release like inflammatory mediators like histamine, and they are also responsible for inflammation, killing of microorganisms. Leukocytes, these are different types of WBCs, what we have studied in detail in physiology. Same information you can write you to elaborate your answer. Whatever you know, you write more. Ultimately, what we want is marks. Okay. So in connective tissue, we have different types of fibers, like we have collagen fibers, we have reticular fibers, we have elastin fibers. Okay. The most abundant of all fibers in connective tissue are collagen fibers.
Collagen
Okay.
fibers.
So yesterday I told you, so basically we have 4 different types of collagen fibers, but in that book we have seen around 30 different types of collagen fibers. That means different books will give different things. But basically in anatomy, at least we should know these 5 types of collagen fibers. The hardest one are type 1, which are found in bone cartilage. The softest ones are what we find in placental membrane, very thin. Okay. So type 2 we find in hyaline cartilage. Type 3 we find reticular fibers. Type 4 we find in the basement membrane over which cells are resting. Okay, like that we have 5 different types of collagen fibers. Okay, elastin fibers are comparatively, they are less in number when you compare with collagen fibers. Okay. So ground substance, glycosaminoglycans you have studied, no beta, in biochemistry. That is only actually forming the ground substance, glycosaminoglycans. It's a polysaccharide, hyaluronic acid. All this background tissue is actually made up of glycosaminoglycans. Now, this is your question. What are the types of connective tissues? So you have to give this table. Like we have embryonic type, mesenchymal and mucosal. Then we have like general type, we have loose connective tissue, dense connective tissue. Under dense, we have regular and irregular. And then we have reticular tissue, adipose tissue, elastic tissue. Okay. Then we have specialized type of connective tissue under which we have cartilage, bone, and hemopoietic. So it was how many marks question, beta? 5 marks or 3 marks? This is 5 marks only. Okay, it is 5 marks question. So if it is 5 marks, you have to give details better. Mesenchymal connective tissue, it is the connective tissue what we find in embryos, and this connective tissue is totipotent in nature, and it has a capability of giving rise to other